when the concept of an alar sensor is new to you, it's really a matter of understanding that it's the same technology, it's simply a location that hadn't been considered before, and nobody had made a sensor specifically designed for it. And the reason that this is a sensing location that is advantageous is because we all know that the peripheral sensor doesn't work in everybody, and it also doesn't work in the people that it's working in all the time. So it's important to know that there is a non-invasive, easily accessible, readily applied alternative. And the reason the alternative sensor to the ALA works is because you have a protected circulation, because you are it's blood flow coming off of the carotid rather than off of some peripheral blood vessel. Certainly has application in trauma patients who are hemodynamically unstable, patients with sepsis or other conditions where they're on vasoactive pressors causing peripheral vasoconstriction. Somebody who's, for example, just had a heart attack, has a low cardiac output, is peripherally vasoconstricted. The example that comes to mind is in the operating room. A patient with the arms tucked where you don't have access to the arms. I have access to the head. I put a nasal alar probe in its place and I immediately have information. In the case of a trauma patient, somebody with very poor perfusion, as you're sort of sorting everything out, you want to know that you still have perfusion because the pulse oximeter is also a sign of life, helps you differentiate electrical activity from electrical activity without a pulse, so-called PEA. We would be quick to put an alar sensor on if we weren't satisfied or able to get anything from the periphery. I've seen it utilized very effectively as in patients in the burn unit, where frequently you are completely bandaged from head to toe and often the hands are involved, and so the fingers aren't eligible for a sampling site. And in those cases, that's an example of where a sensor is going to be on somebody for a long time because those are generally longer hospitalizations. The nasal ALA has a circulation that comes from two locations. It comes via the external carotid through the facial, and it comes infraorbitally from a branch of the internal carotid artery coming down. Remember, the internal carotid artery is part of the central circulation and really doesn't have much vasoconstriction. And so when you have people who are cold, unstable in extremis, and you still find it important to understand, one, that they have blood flow, and two, what their oxygen saturation is, and you get the heart rate obviously from it too, then this is a sensor that will help you accomplish that. If you think about how we live our lives, we're using our hands, our fingers, we're writing, we're eating, even when we're in the hospital, we speak, moving our hands around, whereas our nasal ALA moves very little. And the other thing is you don't have a cable hanging from your hand. So in terms of being able to move around in bed or get out of bed or get into bed, you don't have this cable coming off of an extremity. And unlike a finger sensor, which is almost has to be destroyed to be removed in most cases, or loses its adhesive ability or gets progressively dirtier over time, an alar sensor is very easy to slide off and then move to the alternate nair ALA.